Good evening, everyone. Welcome to the webinar this evening. It is hosted by the Open Hand Therapy Initiative and is brought to you in association with the University of the Witwatersrand in Johannesburg and the South African Society for Hand Therapists. My name is Erica Coneybear and I will be your host for the evening. Our goal at the Open Hand Therapy Initiative is to help you to become more confident in treating hand injuries in challenging settings. This evening, we're going to be focusing on demystifying the Neuro hand, and we've got two exciting presentations lined up for you. The first one, which will be for 20 minutes, is on managing flaccidity and spasticity, and the second presentation will be focusing on functional retraining. These presentations will be followed by a time of question and answer, so if you have any questions, please put them in the chat in the meantime. Okay, but I'm gonna introduce our speaker for this evening. Jill, thank you so much for joining us. So Jill is an expert occupational therapist, and she has gotten quite a few different diplomas. She's got a diploma in neuroscience, interdisciplinary pain management, vocational rehab, and hand therapy. It's very impressive, Jill, alongside a number of other certifications. Jill worked at Natal Spread Hospital early in her career, and she worked in the UK for 2 years, and beyond that has run her own private practice where she treats adults with neurological conditions, orthopedics, plastics, hands, VOC rehab, persistent pain, does FCEs and medical legal evaluations, and she's also a member of the Mayo Pain Clinic. Jill, thank you so much. You're welcome to share your screen and get going when you're ready.
Perfect. All right, we're all good. You can see the full screen.
That's perfect.
Cool. Thanks, Erica, for that introduction. Yes, we mustn't forget it's been a very long career, so there's been a lot of time to get all that done. Well, thank you very much to the Open Hand Therapy Initiative for this amazing work that you're doing, and also for the opportunity for Tamryn and I to present this evening on the post-stroke hand. We mustn't forget that it will be very similar across multiple upper motor neuron diagnoses because most of them will have changes in tone. So most hand therapists dread treating a neuro hand, and most neurotherapists struggle with a hand. And even after years of experience doing both neuro and hands, I often still find hands particularly challenging. So the audience tonight is a diverse group. So we've attempted to present on what we think would be helpful across numerous clinical settings and levels of clinical experience, as well as some of the expectations that we were made aware of prior to the webinar. So we're going to have a look at why we should always pay attention to the neuro hand, basics of managing flaccidity and spasticity, basic splinting and tips, and then treatment ideas. Why do we need to manage the neuro hand? Well, on average, 10 adults in South Africa every hour have a stroke. That's a lot of hands. Stroke incidence in rural areas of South Africa is increasing, and stroke is also one of the top 10 leading causes of disability in South Africa. And again, the high burden of HIV infection in South Africa also complicates the stroke incidence and the management thereof. We do know that spasticity is a common consequence of neurological disorders, especially strokes, and that the impact ranges from subtle clinical signs to gross interference with mobility and personal care, and that if it's unmanaged, it can lead to complications. The prevalence of spasticity after a stroke increases significantly from month 3 onwards, whereas 43% of our patients are going to end up having increased tone. We also know that more than 2/3 of people after stroke recovered independent ambulation, but less than half of that recovered upper limb function at 6 months. So we have a huge population of people who are not going to regain good movement in the arm or the hand. And they've tried to look at what are the predictive and prognostic indicators that could then help us establish what kind of therapy to give people. But even as far back as 2009 to date, there is no predictive model or conclusive evidence about prognostic indicators. There has been some research around the fact that if we're looking at regaining full hand function by 6 months, we need to have signs of shoulder abduction and finger extension within 72 hours after a stroke. So really not a huge amount of time at all. We also are probably not going to see majority of patients who are that lucky to have that minimal effect post-stroke. So we always need to consider the neuro hand in all the various treatment goals within the IDT, including the interdisciplinary team, which is obviously including the patient and the caregiver. And we must remember that even when we're treating cognition or perception, sensation, neglect, praxis, and aphasia, it all has implications for our treatment of the hand. But the biggest thing that I want to urge us tonight to look at is to reduce complications. Is that even if we're not actively treating the hand, we want to make sure that we don't end up with joint contractures, muscle tendon length shortening, pain, hygiene challenges, and increasing caregiver burden. Always, as OTs particularly, we must remember to treat within a biopsychosocial context, because we know that ill health, emotions, weather, sleep, and lifestyle factors all play an impact on increased tone. And then ultimately, our role really is to facilitate meaningful functional engagements. So in this area of person-centered treatment, and often in low-resource settings, we must remember most people who have had a stroke have an unaffected side and usually a caregiver. So personalized functional goals are frequently your priority, not necessarily treatment of the neuro hand specifically. So use your clinical skills in your specific setting to focus on function and prevent complications. I'm sure we've all seen these pictures of untreated post-stroke spasticity. And in our clinical setting, we see it quite a lot. We mustn't forget that it's not only around spasticity, it can also be around low tone, flaccidity. And this is a client who wasn't treated following his stroke. He's a youngster. And when he was discharged from rehab, because he hadn't had any increase in tone and he was quite hypotonic with no volitional movements, he ended up having a wrist subluxation, which then contracted and has now had to go for surgery. So we don't ever want to see hands that end up like this. Always to remember that there's no one either flaccidity or spasticity, it's a continuum. And generally, people start out as flaccid, progress to hypertonicity, and then slowly to hypertonicity with spasticity and rigidity. And there's varying degrees of that as well. So how are we going to set about treating this if we don't assess it first? So assessment is critical. And generally, if you only do the following, this is what we need to look at, is to assess the spasticity specifically with modified Ashworth or modified Targi scale. Maybe do some kind of an upper limb assessment, such as the Fugel-Meyer assessment. Look at our function with various scores or scales, and then quality of life and caregiver burden. There are many assessments in the upper limb. These performance measures are some of them. I think the Fugel-Meyer is probably the most easily accessible. It's easy to perform. It's lovely to do a reassessment on, and it can also guide somebody who's inexperienced in what are the next stages or movements that we would like to encourage. And then in low resource settings for patients who maybe do have some hand function, the box and block test is easy to fabricate and will also give you valuable information. That's what the Fugel-Meyer assessment looks like. It looks at motor functioning, balance, sensation, and joint functioning, and it's an upper limb and lower limb and a hand. So you can rate the hand in the upper limb segment. Never underestimate the value of self-report measures, the impact of the stroke on the family and on the patient. And then our informal assessments, if you don't work in a privileged environment to have access to standardized assessments, use ADL, use specific activities. And then what I find really helpful is to video tasks. So if a patient has a particular functional goal, we will video the ability to perform it pre and post treatment. So treatment really then, if I can just say, it is entirely dependent on shared therapy goals. If it's only you and the patient who are part of the team, because that's all they have access to, is as long as we're all working on the same thing. And two critical areas to focus on is to prevent complications, because this is not going to go away. They've had a neurological insult, which will never, ever, or 90% of them will not remediate to normal. And then we need to facilitate the next stage of recovery or the next functional goal. Some of the treatment modalities that we would look at are positioning and support, splinting, stretching protocols, specific neurotherapy techniques. So for neurotherapists, our Bobath, Brunnstrom, PNF, multitude of techniques, functional retraining, kinesiotaping or strapping, modified constraint-induced movement therapy, graded motor imagery, and then functional, therapeutic, or neuromuscular electrical stim, whichever one you prefer to call it. I generally go with therapeutic electrical stim because at this stage there isn't really a functional one like the foot. Then focal mechanical vibration therapy is really making the literature in the last couple of years to reduce spasticity. Botulinum toxins, either Botox, Dysport, or Xeomin. And then a lot of our patients will end up having to go to surgery because they haven't been managed correctly and they're going to need to have contractures released or muscle and tendon lengthening. But surgery is also not only indicated for patients who have been severely affected. It might be used like tendon transfer surgeries to assist a patient with an improvement in function. We look a bit more specifically at flaccidity, is that most of our patients will go on to develop spasticity. And as we've said, we need to prevent complications from occurring. We also in this stage would concentrate on caregiver training because it's quite difficult to manage somebody who doesn't have a lot of tone, and to make sure that we're not either exacerbating or causing a subluxed shoulder and wrist. So we would look at positioning to prevent the subluxation. We would also manage edema, either with a splint or with pressure garment glove. And this is a gentleman whose hand was not splinted. He carried on with persistent edema. His MCPs contracted into extension and his IPs into flexion. So he started getting some movement back, but we couldn't use it because the joints had already contracted and needed surgery. We also want to prevent complications such as muscle and tendon length shortening. So even if there isn't much tone, just purely by not being in a good position, we run the risk of that. And then to manage pain. A big thing in neuro is to prevent learned non-use. So by positioning a patient like this in the initial stages, would have that arm engaged and would be a much better option than for us to keep somebody in a sling. So there were a few questions around the use of slings in neuro. There's no right or wrong. I think each case needs to be adequately evaluated. But we must remember that an arm sling is going to really encourage learned non-use. It doesn't half the time address subluxation, and it often leads to contractures of the shoulder, elbow, and hand. So we need to be quite cautious in its use. Expensive splints like the Omonurexa are wonderful because they generally ensure, unlike an arm sling, that the head of the humerus is well seated in the glenoid fossa. But again, it's quite expensive. The upside of it is that it allows still really good functional use of that arm. So what can we do if we don't have a huge amount of money to try and prevent something like this? Is for us to look at a resting splint. So here we would prevent subluxation of the wrist. We would manage the web space, keep the MCPs flexed and the IPs extended. We would also, if we didn't have splinting material, we could use a pool noodle that had a strap through it to keep the fingers out of the palm. And even these off-the-shelf wrist extensor splints are quite helpful. These ones are generally about 180 Rand, and I've even seen one on Temu for 100 Rand. So those often together with a pool noodle will be helpful, because if we're only addressing one or the other, we are going to contract somewhere, either the fingers or the wrist. We mustn't forget that if we're going to immobilize somebody, we are making changes to the hand representation on the motor cortex and often the sensory cortex too. So please, we don't want to add to learned non-use, and we don't want to immobilize. We've got to be cautious and judicious when immobilizing anything in a sling or a splint. For spasticity, I've chosen 3 areas to focus on out of that list of treatment modalities because that was what came up in the expectations of the webinar. We use Botox a lot in our practice, or we should be saying onabotulinum toxin A. We predominantly use Botox, so I'm going to just refer to it as Botox. Apologize to everybody else if they feel this is advertising for AbbVie. But this is a lady who had massive contractures of her hand, or shortening, I should say. She came in because the caregiver wasn't able to get into her palm and the skin was macerating and breaking down. So in that instance, we did Botox. She was splinted, and then we managed to get her hand out adequately that the caregiver could get into the palm. So we mustn't forget that Botox is a focal agent. If we've got generalized spasticity, we're going to use medication for that or other treatment modalities. But if we're looking at focal spasticity, then Botox is amazing. Also, not only for very severe spasticity. We know that if we get in early, even in severe spasticity, we can actually manage that spasticity better. And in less severe spasticity, we can fine-tune some of our treatment goals by adequate assessment, clear defined goal of why we're Botoxing, good injection of adequate doses, and then post-Botox therapy. So these are particular doses related to Botox. I do know that Dysport and Xeomin are slightly different, but these are the most commonly injected muscles. And then on the right-hand side are the doses that are predominantly used. So outside the bracket is the common dose, and inside the bracket is the kind of acceptable doses for those muscles. And then just a comment on this, please don't think that you're going to save money by giving a low dose or spreading the dose over a wide treatment area, because it's going to be ineffective. We need to determine what the goal is as a treatment team, and then give an adequate dose and really make sure that we are maximizing the effect of it. We often see patients who come in and say, oh no, they don't want to go for Botox again, they've had it. And when we examine it, it was a very minor dose, and it was given in the shoulder, the wrist, the hand, and the foot. So we're not going to have good. And there was no treatment goals or post-Botox therapy. Another treatment modality that was asked about was therapeutic electrical stimulation. I do use it a lot for multiple reasons, particularly if we're trying to facilitate extensor movements, because most of our forearms and hands or wrist and hands will be in flexion. These are just some of the electrode placements. This here is for the wrist extensor. This here, a third of the way down the forearm, is for the finger extensors. And then I swap the electrodes around, and I put the active electrode over the extensor and abductors of the thumb. And then the neutral one, a third of the way up the forearm at an angle across the EPL and EPB muscle bellies. And I seem to have quite a nice improvement in abduction. So it's not the typical way of using it. And then splinting. You'll see from the number of slides devoted to this where my bias lies. In my personal opinion, I think every single neuro patient needs some form of splint if there's any upper limb dysfunction. There's a lovely guideline posted by the College of Occupational Therapists that's also freely available, and you can read through some practical tips on how to manage the hand. Then the various types of splints are generally static or dynamic, and also these days robotic. And we divide it into rigid to soft. We won't have time to go through everything. So the most commonly ones that we use are in a flaccid or hypotonic hand. We would generally use a resting splint. And then if there's any tone, we would use this either, there's millions of names for it, but anti-spasticity or dorsal volar splint. Because if we try and put somebody with spasticity into a resting splint, generally the wrist pops back out. We might also use splinting with a wrist extensor splint here for somebody who we're trying to block wrist flexion and retrain the brain. We only ever do this if they've got really good volitional finger extension. Otherwise, with a tenodesis action, we're just going to encourage shortening of the flexors. Sometimes splinting is as easy as just a face cloth rolled up in the palm, because that's all we can get. And then I quite commonly use a plumbing conduit or piping of different circumferences that I then cover with a toweling cover that can then be removed and washed, and then the patient has a couple of covers. Soft splints do have their place, and generally only where there's not a huge amount of tone and around a specific functional goal. And again, that needs to be really worked on, and often there's no set recipe for that. In our neuro patients, often we'll see swan necking that occurs, and these little oval 8 splints work nicely for that. And then on the bottom left is a gentleman who had some nice return of finger movements, but his index finger and his thumb kept coming into flexion every time he tried to use his hand. So we put some Botox into those muscles and there was a massive improvement. And then he came back and said he's discovered that if he puts these tongue depressors on as a splint, then his ability to extend his finger and thumb is so much better. So that is the splinting that we then did for him. It's little thermoplastic dorsal splints, and you can see how beautifully it pulls him into extension. And then that was kinesia tap over the middle finger. Dynamic splints could be a little challenging. So the only thing I want to really say on it is that when we look at the cost of commercially available dynamic splints, we've got to be sure that the number of therapy sessions that it equates to wouldn't be better used in therapy. And we mustn't forget as well is that if we've got a dynamic splint like the top left, is that the amount of force to overcome the extension increases your flexor tone and increases your flexor muscle strength. So if you've got no active extension, then we're constantly working into the spastic pattern. The bottom left here is a robotic hand splint, which is really lovely, a massive price, but it works reciprocally. So there's active flexion and extension. And then for isolated finger flexion and extension and individual finger movements, this music glove is an amazing piece of equipment. So if we are going to splint, I think there was somebody asked about preparatory techniques. We can ensure that there's warmth. We can even keep the limb warm prior to splinting, slow shaking of the limb, slow rocking of the body, prolonged stretch, weight bearing, and then positioning of the body and the limb to be splinted so it's fully supported. Sometimes I'll use therapeutic electrical stim pre-splinting. And then also to remember, it's not only about the patient. The environment needs to be relatively warm, your hands need to be warm, and the rate of your movements must be quite slow. So if we're stressing and pulling and pushing, that increases tone. When we are splinting, make sure your patient is well supported. In the beginning, it's often helpful to have assistance of another person. Please never use splinting material or thermoplastic material less than 3 millimeters and non-perforated if we've got a lot of spasticity, because we are not going to have a splint that either lasts or is functional. And then don't take the patient to the end range of spasticity and splint. Always splint a little bit below that, and sometimes start very gently and then serially extend the wrist or the fingers. Paper patterns are critical so that we can show a correct fit. It's sometimes helpful to use the unaffected hand to make the pattern, but then when you do cut it out, remember to invert it. Adhere to your biomechanical principles of 2/3 the length, 2/3 the circumference, and using contour so that we've got as much structural strength in the splint as possible. Use wider straps and often at angles. In the resting splint that we saw earlier, if there was a strap that went diagonally across the wrist, that would have been a lot better. And then I hate padding, but if you are going to use padding, please make sure that it can be changed regularly. And I have found that super absorbent cleaning pots work beautifully for padding. And then just my last slide is to share with you, I normally, if I'm going to make that dorsal volar splint, I only heat up the finger or the hand part first, so that I don't have the entire splint stretching and creating a big gap over here. Okay, let's just decrease that volume. And then we slowly mold the fingers, get them out nice and straight, fold the sides up. And then I have a look underneath to be sure that I'm not folding it in, because that's a common mistake, is that it folds in towards the hand and creates a pressure area. Get the MPs and the IPs into a nice position before the material hardens, and then get your contour. And then I go back and I heat up the forearm parts. So now I'm able to hold onto the hard finger pan, which then gives me a little bit more option for not causing the splint to stretch out and to be able to handle it a bit more effectively. Patient is well supported. I'm sure you can already see there's a few issues with the splint, but they got corrected. And then very gently to pull that forearm piece on. Don't stretch it, because then you end up with a huge area. And I've seen often that this bit ends up back on the wrist, which isn't going to give you good stability. Then we've got nice long, I call them wings, which give you a little bit more structural stability there. Make sure you're flaring your edges so it's not going to dig into your hand. And then you'll come back and make sure you're well aligned, because it often goes skew. And you'll sort out a space for the ulnar head. So ensure you come back and make sure that there's space for that ulnar head so that there's no pressure area. Then in the splint, I'm sure you noticed that area was originally quite, it was digging into her. So we flared that and rolled it back before we put the thumb on. Then I normally put the forearm straps on to hold that part stable. And then I come back and I mold the thumb separately. And then I'm just going to go through that quite quickly. Then once I've got the thumb in a really nice position, I'm happy with a web space, that the IP of the thumb is extended. And I always coach my patients beforehand, please don't help me, even if it looks like I'm not coping, because normally they're trying to assist when they see that you might be struggling a little bit, and then it becomes a bit problematic because the tone increases in the affected hand. So her thumb is flexing now, but you can see that the actual splint is straight. I mark it with a pencil, and then I remove the thumb from the splint, take the splint off, and then attach the thumb really well off the patient so that it stays there. And that's it. Thank you.
Thanks so much, Jill. That was excellent. So I'm going to introduce our next speaker, Tamryn Turner. If you can turn your camera on. Nice to see you, Tamryn. I'm glad you got in. So Tamryn is currently busy with her virtual hand to shoulder fellowship through the Hand Therapy Academy in the USA. She worked at a tertiary hospital in Garankuwa, where she developed her passion for hand therapy. She then went over to take over Melanie Lotte's practice in Kempton Park, which she's now doing full-time. And in addition to her neuro patient load, she sees a variety of hand conditions and trauma of the upper limb. So Tamryn, thank you so much. You can share your screen with us. And then at the end, we'll come back to any questions in the chat.
Today I'll be presenting on the functional hand retraining for patients with strokes to regain functional movement. So my talk is very practical, so I'll be using a lot of videos just to show you how to start to normalize the tone and little tips and tricks that you can use. So I think it's important that as a neuro OT, we would actually start with the trunk and then move our way to the shoulder, to the elbow, to the wrist, and then the hand. But for the purpose of tonight's presentation, I'll just be focusing on the hand. You can change the slide. Here we go. So I'll be using the Brunnstrom Stages to share some tips on retraining CVA hand function. So the Brunnstrom approach acknowledges that before normal movement can be restored, there will be a period of abnormal movement. So we use the Brunnstrom Stages to assess the progress of stroke recovery. Another thing that I want to add is that the Brunnstrom Stages is our functional approach, and the NDT stages, which is our neurodevelopmental techniques, is our preparatory and our facilitatory techniques. So that's your weight bearing, your deep compression, your proprioception, sweep tapping, and all of those things. So just to go back into Brunnstrom, as you can see in the slide, that there are 7 stages. So stage 1 is our flaccidity. Stage 2 is when spasticity appears. Stage 3 is with increased spasticity. Stage 4, decreased spasticity. And stage 5 and 6 is when the complex movement starts to return. And in stage 6 when your spasticity starts to decrease. And then obviously the last stage is when you start to get normal, when your normal hand function returns. You can change the slide. So relating to the hand, the flaccid tone for stage 1 and 2. So this is, as Jill showed in her presentation, when we have no active movement exists. So the movement needs to be facilitated, and we'll do this by using reflexes, associate reactions, and proprioception to develop muscle tension and muscle movement. So how do we start to facilitate the increase of tone? Practical ways that I sometimes find helpful is with myofascial release. So you'll use, I don't know if you can see my arm, but myofascial release at the extensor origin or the lateral epicondyle is usually one of the techniques that I'll use. Sweep tapping as well. I don't know if you can see that on my forearm, but you also start, and what that does is it starts to stimulate the neural pathways of the brain so that we can start trying to elicit tone. Another technique is gravity eliminated supported movements of the wrist. I've got a little video that I'll show you to help explain what I mean. Joint compressions of the wrist, extensor activations. I've also got a video that I'm going to show in my next slide so that you can actually see practical ways and techniques to use in order to start facilitating the flaccid tone. And then the last point is maximal effort of the unaffected hand. So that's when you could start squeezing a washcloth of the unaffected hand, and this would start to elicit a response in the affected hand. You won't always see active movement immediately, but what you'll start seeing is that maybe you'll have a little bit of active movement in the fingers in order. You'll start seeing some sort of movement happening. And then as a side note, these practical techniques that I'm talking about, repetition, I can't emphasize that enough. The more it's not always about doing a wide variety of techniques and activities. If you stick to your basics, you'll be able to start seeing a response. You can change the slide. So this is my first video, and this is where I'm starting to talk about the gravity eliminated supported movements of the wrist. So you'll get the patient to actually lie on the affected shoulder. And what you'll do is you'll then let their arm be placed in front of them. And then the associate movement is you'll then start asking them to flex and extend the wrist. And this is usually if I want to start eliciting any sort of active wrist extension. This is a little technique that I find helps to start to do that. You can change onto the next slide. And this is my little video to explain the extensor activations. So, and what this will do is this will stimulate the superficial and sensory nerve receptors and the muscle bellies, because what we want to do is we want to create that reach, release, and grasp of hand function. You can change the slide. Here we go. So now, as our spasticity increases in the hand, this is as we move to stage 2 and stage 3 of Brunnstrom. Now you can start to incorporate your weight bearing of the affected upper limb. Another practical technique is when you sitting on, you ask your patient to sit on a chair with the affected hand between their legs, and you can sort of start to practice tenodesis. Sometimes I use a sponge or something light. I'll also show you a video of that coming up. And then also in stage 4 and stage 5 is when this is when your complex movement starts to develop, and this is when I'd usually start training finger extension of the wrist. As well as then moving on to stage 6 when you can start training your thumb dissociation and your opposition training. You can go into the next slide. So you can see over here that what I'm trying to achieve is I've asked the patient to put their hand between their legs, and I'm starting to get a tenodesis reaction going. And you can see in the video again that he starts to get his wrist into extension and then start to release with the fingers extended. You can go into the next video. So this is as complex movement starts to develop. And this is a little practical technique that I use in order to get finger extension going. So what I'll do is I'll ask the patient to put their hand over their knee and with their wrist in flexion, because that will then help me to start elicit some finger extension, just like that. And this is a practical way of how I'll start to elicit thumb dissociation. So what I'm doing is I'm asking the patient to extend his thumb. And I'll use all my NDT techniques prior, and I'll then start to encourage the thumb to dissociate from the fingers. You can change the slide. So don't forget to incorporate your ADLs. And as Jill said, sometimes you won't always be able to improve hand function and get to that normal movement pattern. But what you need to remember is also the more independent that you make your patients, and the more independent and the more things that they can do for themselves, this will already improve their self-confidence, improve their mental health. And ADLs incorporating that affected hand by face washing, cleaning and washing their hands. In ICU, I usually use a sterile bowl, warm water, getting them to use their affected with their unaffected hand for brushing their teeth. At a later stage, washing hair as a bilateral hand activity, brushing their hair, also bathing and showering, just incorporating that affected arm as much as you can, shaving, and the last point I had was toilet training. And then another question in the prelim ask was about government tenders. And when I was in government, we used to order a lot of the long-handled sponges I know were available. There was the button hooks that you could order. We ordered built-up grips and pen grips as well for our patients. So I think if you just look on the tender list, there's a process that you need to follow, and that should help you. You can, yeah. And then activities that you can also incorporate into therapy. So this is more when, with Brunnstrom, when complex movement starts to develop. And that's picking up a cube with each finger and then holding all 4 cubes and then placing them on the table, one finger by one finger. I'm going to show you videos of what I'm talking about. Placing objects into a cup, holding the cup to transfer the cup contents into the second cup, and also using mass grasps as well. Sensory stimulation is so important. So I use a lot of ice, where I would just take ice, put it in the patient's hand just to start to elicit the response. Marble flicking and stereognosis. So you can change the slide. So this is the activity where I'm asking my patient to pick up a cube, and you can use inexpensive things. So if you're in a government setting, you can use bottle caps. You can literally, it's just to get that in-hand manipulation. So you'll ask the patient to pick up one cube or one bottle cap with the index, then with their middle finger, with their ring, and then or with their pinky, and then actually get the grasp. And then ask the patient to then place it back onto the table using, again, the index, the middle, the ring, and the pinky. And this starts to encourage those complex movement patterns into the hand. You can move on to the next slide. And this is the practical activity of just me asking the patient. So he's placing, again, he's getting that finger extension and that pincer grip going. And another thing that I also want to reiterate is, don't forget about pronation and supination. A lot of times you always focus on getting the wrist extension, getting the tenodesis and the finger extension, but you don't focus on actually getting pronation and supination. And what this activity does is it forces the patient to actually engage in that pronation and the supination. to get functional hand function back. You can change to the next slide. And then drawing to get the mass grasp going. So just taking a big Koki pen. What's nice about this is you sort of start to get those wrist active movements going, and you're getting your mass grasp. And it's also the precision training of that complex. Getting the complex hand function back. And sometimes what I would do is I would even ask the patient to go over the same shapes, because it's all about repetition, 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 in order for them to get that complex, or to get their hand function back. You can change slides. And then the window period for stroke rehabilitation. Your first 3 months is when the most amount of changes can take place in a stroke patient. And with strokes, we probably have about 2 years where we can do rehab and we can affect change. But it's also important that you need to assess your patient before. But if the patient hasn't received OT, you can maybe possibly, and it's maybe past the 3 month stage, you can possibly try therapy for 1 month and then see if any changes occur and assess. And then from there, take things from there in terms of if you want to continue therapy or not. You can change the slide. Yeah, and that's my little speech. Thank you.
Thank you so much, Tamryn. That was so practical, and I loved all the videos. We can really see some of those things in action. So we're just going to move into a little bit of time of questions. I see Jill has done quite a bit in the chat already, but Jill, maybe if you can speak a little bit more to Botox. I know you've answered some questions in the chat, but what doctors do you refer to? How do you manage compliance? That kind of thing.
Okay. So generally it's a neurologist. So we're lucky enough to have a treating team in the neuro rehab, and a neurologist who comes out and does the Botox for us. There is quite a move for the medical aids only to approve Botox if it comes with a treating team, with an OT and physio as part of the team. And then I think the most important thing around Botox is that we need to have an established and shared functional goal. So we know exactly why we want to Botox, then we can decide which muscles to Botox, what the doses should be, and then what the post-Botox therapy should be.
Cool. Thanks, Jill. Tamryn, there was a question in the chat. I'm not entirely sure which part of your presentation it was regarding, but about mirror therapy. Do you incorporate mirror therapy into your treatment, or is there elements that kind of have the same principles or work in the same way?
So I think with mirror therapy, can you hear me? Yeah, there definitely is a place. I think it also depends on the patient. They need to buy into it. So it needs to be something that that you explain well before you use it. But it definitely does have a place.
Cool. And then, Jill, there was a question around using electrical stimulation. One of the therapists came across a patient who used that. Have you come across that at all in practice? When is it used? When is it not used?
That's the therapeutic or neuromuscular stimulation that I showed with electrode placements. I did answer the question in the chat. There isn't a particular setting, and I think we've got to be very cautious with patients who buy devices that aren't from a medical supplier. And you can actually get some ones that are really reasonable from high-tech therapy, so you don't have to spend a fortune either. But we've got to make sure that we've got good electrodes, that they're not worn out, patients aren't overusing it, and that the settings aren't too high. So it always must be under therapeutic guidance.
Yeah, thanks. And then Tamryn, would you be able to give any treatment recommendations for a patient who has no voluntary control due to decreased proprioception and touch? So when that hand is just not working, what do you do?
So if the hand is completely flaccid, I think it's the first. I think the first thing I would probably then start doing is, again, like I started with my presentation, is that myofascial release. So what you need to do is you need to start eliciting a stimulus. So I would always start with with a myofascial release to sort of start getting the movement going. The sweep tapping, the active extensions, and all of those things. Basically, the NDT techniques, because the NDT techniques are what you're going to use in order to start facilitating that sensory stimuli.
I think there was some appreciation in the comments about using Brunnstrom, and I don't know, I appreciated that starting at the trunk. Some of the students I've been trying to put into them to start at the trunk are really important. Yeah, thanks, Tamryn. And then for either one of you, maybe one or both of you could answer, but there's been a couple of questions about managing severe pain in the affected side. I don't know if you have any like tips or anything you've come across with regards to pain management.
Yeah, I'm quite happy to answer that one. I just wanted to add a comment too. When we've got hypertonicity or flaccidities, we mustn't forget the value of graded motor imagery. So if we start with the visualization and the mirror therapy, so we can activate neurons in the brain when we're not actually having any motor output. So we're starting in the premotor cortices already. And then just around the pain, I think it's quite important to establish what the cause of the pain is, because it can be multifactorial. So sometimes we'll have patients who have a thalamic stroke, and then that pain is really hard to treat. Need lots of meds for that. We could have pain coming from positioning, from spasticity, from psychosocial and emotional factors. So I think it's a good thing to assess all the aspects, and then very often Botox not only has an effect on the muscle spasticity, but it has an effect on pain too. So there is also an afferent uptake from the Botox, which is helpful for pain.
Cool. Do you want to add anything on, Tamryn?
No, I think Jill, she's amazing on pain.
Tamryn, would you be able to show us on your camera how to do thumb dissociation training?
Okay.
It could be one of your videos.
Sorry, I couldn't. Let me just take my watch off. So basically, if the patient has a completely flaccid thumb, what I would start doing then is I'd again start with my. You can use like Joel also spoke about, like TENS, but what I sometimes do is I would start massaging just here at the EPL region over here, and what I do is I'd also do my sweep tapping as well. And then what that then does is I then start to elicit that active extension. Once they can then actively extend, then I'd start sort of in with a half lever with my form. I don't know if you can see my hand, and then start getting them to go into that pronation, and then coming back up to neutral, and then going supination, and that's how it starts. But you'd start to use your NDT technique of either sweep tapping and your myofascial. First, get them to first extend the thumb, and then start with either your pronation and your supination.
Very cool, thank you. And then, Jill, would you mind explaining why you said immobilization changes the representation of the homunculus?
On the sensory motor homunculi, because we're not getting feedback from that body part. So we're keeping something still, and there's research that's shown even in a normal arm with no difficulties or disability, within 24 hours of a perfectly good arm being immobilized, that there is already neuronal disbursement happening in those areas. So if we're not getting sensory feedback and we're not using it, then we start to get other areas taking over those neurons that are not being used.
There's been a couple of questions in the chat about TENS, TENS or TES courses.
So
I think one of the question was if OTs can use it. Yeah.
Trans-electrical nerve stimulation, transcutaneous electrical nerve stimulation, and it's used for pain, and the input is submuscle contraction. So we don't want a muscle contraction when we're using TENS, and it works on a totally different mechanism to TES, or therapeutic electrical stim, which is neuromuscular electrical stim. And that one we do want a muscle contraction from, because that's to try and facilitate movements. So one is for movement, one is for pain.
Yeah, I've learned some new terminology as well this evening. Sorry, I'm trying to keep up with the chat. one question, I've encountered quite a few patients who regain muscle strength and fairly normal tone, but coordination is a big concern. Any tips on coordination? Maybe Tamryn?
I think with coordination, I think yeah, I do a lot of activities. So like using a ball as well. Lots of ball activities with the hand. Yeah, and I think function, like incorporating function. So getting using your ADLs to help you.
There's a question about some challenges with oh, I see we've got into 8:30. Okay, one last question, and then maybe you can continue to answer some of them in the chat after we go. Sorry, we had lots of time, and now it's all gone. But a little bit of challenges in government with having splinting material available. Kind of maybe how do you prioritize who gets a splint, who doesn't get a splint? Yeah.
Should I answer, Tan?
Yeah,
Okay.
sure.
I think, again, it's around who's got the most potential to develop complications. So if you've got somebody who's young, who has potential to recover, then maybe they would take precedence over somebody who you could manage without making a thermoplastic splint for. Or if you've got somebody who's got significant amounts of tone, you might splint them and rather work actively on somebody who isn't as hypertonic.
Cool, thanks, Joel. Let me just share my screen quickly to close off. So thanks everybody. Just a reminder about the questionnaire that you'll get as you leave the meeting. Just a very important announcement. We've had to move our last webinar to the Monday evening, which is on the 2nd of December. We had some challenges with our presenter availability on the Tuesday. So please change that date in your calendar if you have been attending the whole series. And you're welcome to follow us on social media. We've put a QR code on the slide, so if you want to join our mailing list, you can join that really easily, and then you can stay up to date with all of our news and future webinars. We're busy planning for next year, so excited for some more topics. Yeah. Thank you, everybody. Have a good evening. And thank you so much, Joel and Tamryn. It was such a pleasure.